Welcome to Short Stated, a quick hit of the CP Stated podcast, where we take a fast, focused look at what our affiliates are doing and spotlight timely topics in the disability field. Just the essentials here. Clear, concise, and worth your time.
Hello, I am Dr. Maria Kansas Devine. I am a board-certified family physician of 40 years with 11 years experience treating individuals with developmental disability while serving as the former chief medical officer for the Center for Disability Services in Albany, New York. Thank you for joining me. Today I'm going to talk about diabetes with a focus on risk factors, screening, and prevention with emphasis for persons with developmental disability. By the end of the podcast, you should be able to be aware of the difference between type 1 and type 2 diabetes, identify risk factors for diabetes type 2, identify additional risk factors for diabetes type 2 for persons with DD, and identify current diabetes screening recommendations based on the American Diabetes Association. I want to briefly discuss diabetes type 1. This was formerly called childhood onset diabetes. Diabetes type 1 is an autoimmune disease that's often triggered by acute childhood viral illnesses like Coxsackie virus, rotavirus, mumps, and CMV. There is evidence in the research that there is a genetic link to the increased risk seen in Down syndrome and in autism. But in general, there is a genetic predisposition for all individuals who develop childhood onset diabetes. Usually the onset of type 1 is not subtle. It usually presents as an acute serious illness requiring hospitalization with unresponsiveness, weight loss, weakness, and urinary frequency. Type 2 diabetes is a much more common disorder in all populations. It was formerly called adult onset diabetes, but with the increased frequency of type 2 diabetes diagnosis in children and young adults, this was changed to diabetes type 2. It is most often connected to an increased body weight and BMI. In the absence of screening, diabetes type 2 can be asymptomatic for many years. Symptoms can include increased thirst, increased urination, and nighttime urination. Prior to and in the absence of routine screening, diagnosis of diabetes often occurred when organ injury was detected. Organ damage from diabetes can include eye disease leading to blindness, kidney failure, artery damage, including coronary heart disease and stroke, nerve injury that causes numbness, chronic ulceration, and limb loss. Screening is so important because early detection can lead to reversal of diabetes type 2 sometimes, and prevention or delay of organ damage. So let's talk a little bit about risk factors, and I've divided them into modifiable risk factors and non-modifiable risk factors. So some of the modifiable risk factors are elevated BMI and obesity, inactive lifestyle, to a degree, physical limitations from a disability can be modified with appropriate physical and occupational therapy. Sleep disturbances like sleep apnea can be modified and improved with weight loss, but also with CPAP. Food selectivity is a hard one. Many individuals, particularly with autism, are very sensitive to food textures and will tend to choose high carbohydrate, bland foods. But early intervention with speech therapy, with frequent introduction of new foods and healthier foods, can be improved. Other potentially modifiable risk factors include family and caregiver relationship to food. This can be difficult and challenging, but can be changed. We see many families and caregivers use food as either a reward or as an activity in and of itself, as we all do, I'm sure. And family obesity from food choices and lifestyle choices can make changing an individual's diet particularly challenging. But education of the whole family can sometimes bring a reward. We see many individuals with disabilities who are on antipsychotic medications, and in particular, clozapine, olanzapine, quetiapine, and risperidone are linked to an increased risk of diabetes. Risk factors that are less modifiable include a genetic family history of diabetes. You obviously can't choose your relatives. A personal history of gestational diabetes, food insecurity and food deserts, which make the access to healthy foods much more challenging. And housing insecurity has certainly been linked to obesity, as preparation of healthy foods is more difficult. In people with intellectual and developmental disability, in particular in Down syndrome and autism, there is additional risk. In Down syndrome, diabetes type 2 occurs up to 4 times more often in adults younger than 30 compared to neurotypical individuals. And there has been studies suggesting a genetic susceptibility linked to chromosome 21. In individuals greater than 30, persons with Down syndrome have twice the occurrence of diabetes type 2 than neurotypical individuals. In autism, there is some research suggesting increased risk of diabetes type 1 and type 2 related to genetic predisposition. And some estimates show up to 57% higher risk of developing diabetes compared to people without autism. People with developmental disability who have diabetes are 2 to 3 times more likely to be hospitalized with diabetes-related conditions, and rate of adherence to diabetes goals and screening may be as low as 25%. So let's talk a little bit about general screening guidelines. There are different guidelines that are available. I am referencing the American Diabetes Association guidelines, which are the ones that I have followed. So all asymptomatic adults 45 and over with normal weight should be screened every 3 years if they've had a normal screen. Annual screening for lipids and diabetes is also recommended for all persons on antipsychotic medication. And all adults 35 and older who are overweight or obese should be screened annually. And all individuals aged 10 to 35 with overweight and obesity and at least one other risk factors should be screened. Risk factors for additional or earlier screening include a family history of diabetes, being overweight or obese, having an inactive lifestyle, Individuals who are already diagnosed with high blood pressure, high cholesterol, a personal history of gestational diabetes, coronary artery disease, fatty liver, or polycystic ovary syndrome should also be screened more frequently than the general population. For special populations such as Down syndrome, recommendations include screening earlier. For individuals with Down syndrome and obesity, it is recommended that individuals be screened every 2 to 3 years starting at age 21, or even earlier if other of those risk factors exist. For people with Down syndrome and a healthy weight, the recommendations include screening every 1 to 3 years after the age of 30, or earlier if other risk factors develop. In autism, there's no specific guidelines for diabetic screening other than the general guideline. There are many different ways to screen for diabetes, but probably the most accessible is screening using hemoglobin A1C. For the general population, the recommendation is age 35 to 70 who are overweight or obese every 3 years, all adults age 45 or older every 3 years. So pretty much screening is the byword. More frequently, and at a younger age. I did want to mention a few words about prediabetes, which we've all heard more of and is more obvious now that we are increased the frequency of our screening. So the definition of prediabetes is based on hemoglobin A1C, which is a blood test that can be done in an office-based setting from a finger stick, or it can be done on a blood draw. So normal hemoglobin A1C is less than 5.7. Prediabetes is defined as a hemoglobin A1C from 5.7 to 6.4, and diabetes is defined as a hemoglobin A1C greater than 6.5. The good news about prediabetes is for many individuals, it can be reversible. Developing diabetes is not inevitable and can be changed, improved, or managed with weight loss and an improved diet. A diet featuring more low glycemic fruits and vegetables and lean protein, and a correction of high body weight. However, approximately 70% of people with prediabetes will progress to diabetes within 10 years. So changing lifestyle in a prompt way is critically important to help prevent diabetes. People who have prediabetes on screening should continue to be screened annually to assess for progression. The other question I frequently get asked is, what role do GLP-1 medications have in the treatment of diabetes and in the treatment of prediabetes in people with developmental disabilities? Many studies are underway at present to look at the role of GLP-1 in certain kinds of compulsive eating, including those individuals with Prader-Willi. So we know that there is a brain response to GLP-1s that may help individuals with certain conditions. They do have their downside. In particular, the most effective ones tend to be the injectables, although there are oral GLP-1s available. The biggest barrier to their use, however, is cost and insurance coverage. Medicaid currently will cover GLP-1s in the presence of diabetes, but will not cover, as is true of many commercial plans as well, they will not cover GLP-1s for pre-diabetes or for the diagnosis of diabetes. So this makes these medications less usable. So what can we do about diabetes and pre-diabetes? I think the biggest message here is that diet matters. We want to try to broaden food repertoires as is possible by frequently introducing healthier choices, fruits, vegetables, proteins to individuals who have significant food selectivity. We want to avoid using food, particularly unhealthy foods, as treats for rewards, as activities and incentives. We want to always encourage healthy choices and healthy portions, and encourage activity in any way. Activity alone generally does not cause weight loss without diet modification, but is still a healthy choice and can enable individuals to have some leeway in their diet for special occasions.
That's it for this edition of Short Stated, a quick hit from CP Stated. Thanks for tuning in. For deeper conversations, inspiring stories, and more from across our network, be sure to check out the full CP Stated podcast wherever you listen. Until next time, keep moving the mission forward.